I think we have fantastic data sets in bladder cancer, all the way from non-muscle invasive disease to metastatic urothelial carcinoma. I think in summary, in the non-muscle invasive bladder cancer, the data with this pretzel, the TAR-200, looks very promising. And of course, this is early days. There are only 30 patients, short follow-up, but the complete response rate, clinical complete response rate, was 77% based on independent review committee with that pretzel TAR-200 that delivers gemcitabine intravesically inside the bladder. And I think that's a great start. This agent is not ready for prime time, but I think there's great promise, and I think the program keeps developing. There are 4 Sunrise trials. Sunrise 1 is what we discussed with the TAR-200 monotherapy in BCG responsive disease. We have 3 other Sunrise trials. Sunrise 2, muscle-invasive bladder cancer with a checkpoint inhibitor plus TAR-200 versus chemoradiation. You have the Sunrise 3 in BCG-naive space and Sunrise 4 in neoadjuvant therapy in muscle-invasive bladder cancer and cisplatin-ineligible patients. So overall, the TAR-200 program, I think, is very exciting. Not practice-changing right now, but really, really promising for down the road. And obviously, metastatic urothelial carcinoma, we saw really important data. The overwhelming success, and I think in terms of transformative improvement in overall survival and PFS came from the EV-302 trial, Pembro EV versus chemotherapy. This was an impressive PFS and OS benefit with hazard ratio 0.47 for overall survival benefit with Pembro EV. Obviously, we have to think about how we can implement this regimen in different countries because it's an expensive regimen, so access and uptake will be important over time. There are many questions with it. What do you do in patients with prior checkpoint inhibitor exposure? What about the escalation of therapy, specifically with EV? Dose management modifications, dose reduction, therapy breaks with enfortumab vedotin are important to discuss. And what do you do with ongoing trials? What is a proper control arm in ongoing trials? But definitely pembrolizumab and enfortumab is the new standard of care for both cisplatin eligible and ineligible patients in countries where pembrolizumab can be reimbursed. In patients who are cisplatin eligible, Gemcis nivolumab prolonged overall survival and PFS compared to Gemcis. This is upfront Gemcis nivolumab with continuation nivolumab for up to 2 years. And that trial, CheckMate 901, was also positive. So in countries where pembrolizumab is not reimbursed, I think Gemcis nivolumab is a very attractive option for cisplatin eligible patients. And I think the Javelin bladder 100 paradigm is still very important. This has been practice changing. And in countries where pembrolizumab is not reimbursed, having CarboGem followed by available maintenance in cisplatin ineligible unfit patients is standard of care, as I mentioned, in countries where you cannot have access to Pembro EV. We saw data from the third trial with erdafitinib versus pembrolizumab and erdafitinib versus chemotherapy. Very important data sets, and I encourage the audience to look to those manuscripts. I think it's a great time for patients and really, really change improvement in the longevity and I think also in the quality of life of those patients.